Okay, thank you for returning timely. And the next speaker is Dr. Anidu Pathirana, consultant cardiologist at CSTH Kalubowila and the president of Srilanka College of Cardiology. So it's over to you.
According to Wikipedia, St. John's College.
Good morning. First of all, let me thank Cardiology Society of Medicine for inviting us here as Srilanka College of Cardiology. And I'll be giving an update on the practice essentials of systemic hypertension. You know, it's a vast topic, but I'll be focusing on few areas, mainly the new trends. That is, these are the new trends, main trends that is seen in last few years, and there's a trend to redefine the diagnosis of systemic hypertension with lower threshold to diagnose. And also, when you are diagnosing or monitoring, there's a tendency to advocate use of out-of-office blood pressure measurements in more wide scale. And another trend is to lower the blood pressure targets when you treat to achieve. And when you're treating with drugs, to use combination therapy, and it is what is been advised is to use in a single pill of drug combinations. So, but the challenge is to implement all these changes, especially in low resource settings, because they will all will require resources, increasing use of more resources. So, getting back to the basics, so hypertension is a huge and growing burden globally, and there are some regional disparities in the globe. But the one tendency they have noted is that prevalence is shifting. High prevalence is shifting from high-income countries to middle and low-income countries. That is epidemiological trend. And hypertension is the leading cause of disease and death worldwide. That is the leading cause because it is a mother of many diseases, mainly cardiovascular diseases and the kidney diseases. And it is a leading cause of all-cause mortality. And when you this mortality risk is if you take it's a more or less a J-shaped curve. The lower if you have very low blood pressures, the mortality rate goes once again. But if blood pressure is higher, from as low as 110, 115 and 75, the risk of death goes up exponentially in a linear fashion. So it is seen independent of presence of other risk factors like dyslipidemia and smoking. So blood pressure is an independent risk factor, very strong risk factor for cardiovascular death and total deaths. And one important thing is that though it is a risk, not only it's a risk marker, it's a very good risk modifier. If you control the blood pressure, and even a small reduction will have magnified effects of the favorable outcomes in the adverse outcomes. So that is a good aspect of it. Blood pressure control will help in modifying, in achieving a favorable clinical outcomes. So, as the blood pressure remain largely asymptomatic, so it is very difficult to get diagnosed unless you actively screen for them. Many people will be missed. They will be having high blood pressure but won't be diagnosed. And even those who are diagnosed, most of them are getting untreated because treatment itself is that disease itself is asymptomatic. When you treat, they might get some troublesome symptoms, and they don't. And it's also involving visiting a doctor frequently. That sort of things will prevent patients getting treated, as well as they are not getting optimal treatment. So it is always an epidemiological dilemma to achieve the good outcomes in a very high prevalent condition all over the world. So as you know, blood pressure is a biological variant, and it varies with the circumstances, as well as physiological plus external stimuli will change your blood pressure, as well as there's diurnal periodicity. So there will be blood pressure will be high during daytime activities, and with sleep it will drop, it will dip, and in the early morning hours there's once again a phenomena called early morning surge, and it is associated with some of the acute adverse cardiovascular events. You see more MIs, more CVS during the early hours of the day, and this is attributed to morning surge, what is called exaggerated morning blood pressure surge. And these are the 4 questions I am going to focus on out of the whole wide range the subject. So what are the blood pressure values to diagnose high blood pressure? So and what are the targets to achieve in terms of blood pressure, and when to start treatment, and what is the best regimes to choose? And so the answers are come from the guideline. Answers are depend on the available evidence, and available evidence are summarized in forms of guidelines by various professional bodies. The problem is guidelines. There are so many guidelines, and so one of the out of the recent guidelines, so this lot of American bodies get together and in 2017 formed the guideline and also updated in 2018. And there's another guideline by European, other side of the Atlantic, European countries, 2018. And then International Society of Hypertension produced last year, just the most recent guideline. In addition to that, there's a very practical guideline designed by the Department of Defense of America, that is Veteran Affairs. That is also a very practical guideline. That is also 2020. So problem is that there are ambiguities and differences between the guidelines, and we need to harmonize. We don't have I think at present we don't have our own guideline. That is one of the things that is being highlighted. Also, most of the developing countries do not have their own guidelines. And what we will need, I think we won't be producing in terms of trials, but we will need to harmonize what is available evidence from we have to import evidence from the other countries and maybe to produce our own harmonized document. So to go through my first question, what is the threshold to diagnose? As you know, blood pressure is a normally distributed. This systolic distribution in the population, it is normally distributed. Most of the people are in the middle, and it's the diastolic pressure. And so definitions, all the definitions are arbitrary definitions based on the clinical trial-based evidence, where you find the blood pressure level at which the intervention to improve the outcomes that is defined as the cutoff point to define hypertension as a disease. So there the benefit will outweigh the risk. The level of blood pressure, there the benefit outweigh the risks as seen in clinical trials. So this is where this will change as the evidence gathers, and this is where the ambiguities about among the various associations exist also. The European guideline, the level remains 140 and no 90, and International Society of Hypertension also retains that same level, that is 2020, whereas both American bodies have gone lowered their systolic blood pressure threshold to diagnose, mainly because by the diagnosis of the treatment is based on the previous data that was seen in experimental data, which I show the graph, where they have seen the cardiovascular risk starting from 115 to 75, and also it was further strengthened by the recent trial called SPRINT trial, where they lowered the systolic blood pressure with treatment from 140 to 120 and shown total mortality benefits in patients who are not diabetic having cardiovascular disease without stroke. So that evidence led to this lowering the blood pressure threshold as well as the targets in American guidelines. So the cutoffs are based on the office, that means clinic measurements that are done on repeated assessments. So when it comes to how to measure the blood pressure, so it can be invasive, non-invasive. We usually the invasive things are directly assessing the blood pressure in the arteries or even the aorta. So that is not can't be done in ambulatory settings, day-to-day practice. So it is usually we go by cuff device-based methods where you measure the upper limb blood pressure over a brachial artery using various devices, auscultatory or oscillometric devices. And whatever the device that you use, it is very important that they are validated, and not only that validated, it has to be calibrated regularly. Most of the blood pressure meters are not calibrated. So you might see when in our practice at even private hospitals, blood pressure meters, if you take 2 meters, they will give two readings, right? They are not calibrated. So there are two settings where you will measure your blood pressure. One is clinic setting, and that is called office in other countries, right? And so it is out of office, right? In office also, the tendency, new trend, what they advocate is to use this machine where the patient himself can, or this automatic machine can measure the blood pressure and unattended fashion. And I think in the COVID situation, COVID era, this is the solution, and this is better also. And measuring the blood pressure in the clinic, you can't keep a distance of 1 meter, very difficult, right? So that's why our patient COVID era blood pressure, high blood pressure measurement is these patients are not getting a good deal at all. They are not being measured blood pressure, which I have been telling that it's a very important factor to risk modify and the strongest risk factor. So there's a time has come for us to in the clinic to have this device, or to advocate them to self-monitor their blood pressure at homes, because this is also a very practical way, and it's a good option for distant management like home setting. So otherwise, we have to popularize this device. These are costly, and these are available. And but out of the blood pressure measurements wise, the ambulatory measurements is the most accurate, because it correlates very well with the cardiovascular outcomes. So measuring blood pressure at home or in the clinic, it's not a simple task. It has got about 15 essential steps, right? And if there's any discrepancy of the standards, the pressure readings can be inaccurate. But problem is that these all 15 measurements will take, if you follow this, will take about 8 to 10 minutes to complete. So that is not happening in day-to-day practice. So that is the problem with blood pressure diagnosis and management, and that's why a lot of people are left out in the community, being not treated, being not detected, and not being treated adequately. So he's a man who has been chairing a clinical professor in clinical medicine, who has chaired many of those guideline committees in America. And what he has to say, he is emphasizing that errors are common. And even though that is the procedure that is being done most commonly, that is the procedure that is done in the sloppiest manner. So another thing about when you take clinic blood pressures or office blood pressures, you can't decide especially the treatment decision based on a single value. So you have to take multiple readings at multiple locations. So if the reading is low, initial reading is low, you can just, no further reading is necessary. But if it is higher than this 130/85, you have at the same setting, you have to take 2 more measurements, at least 30 seconds apart, and average the last 2 readings out of 3 readings. Right? Then if you find after the averaging the last 2, if the blood pressure is very high, right? 180, 110, what you should be doing, you should ensure that there is no acute injury, acute illness, or acute pain or distress that can give rise to a physiological increase in blood pressure. If that is there, you think so, you have to get the patient down after getting the illness settled, and then this is about all first encounters. How to do. Then at that level, if you have to better to ask for emergency symptoms and signs, because these very high blood pressures can be achieved associated with target organ damage, severe with acute cardiovascular, especially cardiovascular and renal bad outcomes. Right? These are some of the things that you have to screen. And if they are there, those patients can't be sent home. These symptoms are there, you have to admit them and get the specialist opinion. If they are not there, you have to work on other urgent situation where there's whether there's already end organ damage which is not evident clinically, and have that in place, and also to address whether there are any cardiovascular risk factors, because most of the time these people are either dying of cardiovascular diseases, then see whether they are established cardiovascular diseases, and your confirmation can be done in the same day or within a week. You can get him back if he is not very urgent and do that, right? And the other category, where in between category 130 to 160 to 180, you need to still get them down for a review visit and do multiple measurements. And but the new trend in other countries is to get that group of people to confirm with out of his blood pressure, where you ask them to do home monitoring or do a 24-hour ambulatory blood pressure monitor if it is possible and if it is available. Otherwise, it is once again repeated measurements over several weeks, maybe several weeks. You don't have to rush in because there are no acute symptoms, and so this is how it should go. So these are the defining values. So when you do that assessment, depending on the first, I was talking about previously first encounter where you screen for hypertension, and these are the, if you find persistent values, these defining values. If it is in the clinic, this is ESC. I will go for the ESC and ICH, International Society of Hypertension Guidelines, and 140/90. I think this is good enough for our country rather than 130, lowering it to 130. And in the home setting, it is 5 millimeters below. And out of the ambulatory settings, there are three groups: at daytime, nighttime, and 24-hour average. Usually, some of the guidelines, they rely for defining purposes, mainly the daytime, where the patients are awake and engage in activities. So that is, once again, like home pressure, it is 5 millimeters below this 140/90. So at the diagnosis, when you arrive at the diagnosis, you can diagnose it depending on the categories. Then if you decide to do, if you have facilities to measure out of his blood pressure, along with the office blood pressure, you can get further information by getting the blood hypertension people categorized into 4 groups. Right? If these 2 values are concordantly low, both values are low, below the defined values, that is normotensive. And if it is both values are high, that is sustained hypertension, right? But if the 2 settings readings are discordant, right? The office value, clinic value is low, but you find the values are high on out of office, that is called the masked hypertension, which has been masked by the by your usual clinic measurements, right? That is masked hypertension. And the other category is white coat hypertension, where the people don't have high pressure at home, but it is there in clinic, right? So 4 types of hypertensive states, right? So this is, knowing about this is very important. While the masked hypertension carries the worst prognosis, it is worse than the sustained hypertension, right? Okay, it is about, when you consider the people with normal blood pressure, the outcome risk is about 3-fold higher, right? Whereas white coat hypertension, it is in between sustained and normal people, that is only slightly higher than the bad outcomes are slightly higher. So it is, you can't, there's you in untreated patients where you have not thought about treating, so you should not overdiagnose hypertension by just picking up labeling patients with white coat hypertension as hypertension and over treating them. That is very important. That is why that the guidelines, European guidelines, they say the category where people have blood pressure 130 to 160, you should have the out of office measurement as if it is available and if it is affordable, right? And also the other way, you should not miss the masked hypertension, right? Where you recorded clinic pressures are normal, but because that is the worst case of mortality, right? Morbidity. Therefore, even you call the blood pressure levels in the clinic reaching the normal level, this 120 is towards normal level, they advocate, the people with, that's why I said this is depending on the resources. We can't think about doing this, right? We are not doing nowadays blood pressure measurement at clinic also. So we can't think about, getting the patient to, all the patients getting into a 24-hour ambulatory BP. And so that is the best method of even so-called normal people, right? So-called normal office blood pressures to unmask the masked hypertension, right? Okay. And so this is when it comes to treatment. Treated patients, there are 2 phenomena that is called the white coat effect as well as mask effect, right? When you are treating patients, there can be a difference between this is a difference from the out of office setting minus clinic setting, right? Okay, this can happen, and that has to be looked after, especially the uncontrolled mask effect has to be treated, right? Based on the out of office blood pressure measurements, right? This is very important, right? And so mask hypertension, as I mentioned, so it needs drug treatment, right? Even it is just diagnosed, it needs drug treatment, right? Most of the patient, and you have to target monitor it according to the out of office blood pressure monitor, not with the clinic monitoring. And even in untreated patients, you have to go for this, see whether their blood pressure is uncontrolled at home or out of clinic, and up titrate your drug dose. Right? That is very important thing. Whereas white coat hypertension does not qualify for drug treatment unless there is already endocrine damage related to hypertension or very high cardiovascular risk. So what they need is lifestyle changes and regular follow-up, because some of them can progress to sustained hypertension, where they will record sustain both situations, right? So this is one of the things that I was telling. After if you take diagnosis, you first come, you evaluate, then you see whether these patients are repeatedly having blood pressure and see whether they go above the defining value. And at that point, if you go for out of office blood pressure, you can categorize the blood pressure types into 4 phenotypes. Then next situation where you embark on treatment, where you plan for your therapy, right? And where you have to categorize your blood pressure. This is usually done using the office blood pressure. Okay, average clinic blood pressure. So you will see Europeans, and there's a difference, that's what I told, right? Where they cut off the 130, the starting point for systolic, right? And 80 here, whereas 140 and 90, right? The other categories. So you will also realize, though they give the disease term as hypertension, this is the normal, this is going away from the normal distribution. So this is optimal blood pressure, normal blood pressure, high normal blood pressure, and this is high blood pressure, right? So it is a high blood pressure state, whole range that we are dealing, as Dr. Mubarak was telling about the lipid, same concept, right? Same concept, biological variable. And so when you are doing all this workup initially, when you are assessing for repeatedly through trying to confirm, at the same time you have to look for whether they are hypertension related target organ damage and global cardiovascular risk assessment. And because most of them will die of that, or they will have events related to cardiovascular disease, and see whether there are about 5 to 10% can have secondary causes. Secondary causes, if you remove the secondary cause, that is cure for the hypertension. Otherwise, there is no cure. Otherwise, just a lifelong drug treatment or lifestyle measurements. And also, your drug treatment and the therapeutic treatment might interfere with the process of whether other diseases like asthma, you have to assess all that, and renal disease, right? And at the same time, while you have been preparing the patient to diagnose, you can, lifestyle measures are universal. That is helpful for lipids, everything, right? That there is no bar to introduce those things. And at the same time, self-care, you can ask the patient to buy that is helpful, right? Home blood pressure monitor. And it is always longitudinal care, right? These patients, once they diagnose, has to be followed up long term. And next, when you arrive at a diagnosis after categorizing, next thing is to decide about a blood pressure goal, how much we should achieve. So how do you decide? It is goal. Nowadays, it's more practical and more sensible. Blood pressure goal is a range, especially in the European guidelines, right? And so you can't achieve this very abruptly, and you don't need to achieve this very abruptly unless there is evidence of hypertensive emergency. So another thing, it has to be maintained persistently, because this is a lifelong affair for most of them. Those who have found primary hypertension, there's no cause. This is a lifelong, long-term affair. So it's a matter of controlling the blood pressure lifelong, as Dr. Mubarak was telling about the LDL. There's an analogous thing. So it is once again blood pressure long-term management. Then you can achieve the meaningful reduction in adverse cardiovascular outcomes, right? So as this is focus on the previous curve, we will see this the hazard ratio in terms of the level of blood pressure. This J-shaped curve has a wider in the J part, the wider bend, the inflection point is wider, right? So there's a range that you have to achieve, right? And this is the sweet spot that need to be achieved. So they have found in recent clinical trials, that's why they have lowered it, right? But the first target for the European guidelines, 140 and 19 diastolic blood pressure for all patients, right? But you can go lower, and provided the most important thing is these patients most of them will need drug treatment, and the patient should tolerate the drugs, right? There's no point in making their life miserable to achieve very good results with forceful results with achieving lower and lower blood pressures, right? So then target move to the 130/80, and even young people can give even more lower up to 120, right? And diastolic blood pressure, it should not be below 70, right? See, this 70 is below, it goes up, right? Okay, the curve, the mortality goes up, hazard ratio goes up, right? And so this is a bit of summary. And so this goal, you will realize that goal I'm concentrating on, it's mainly a range, right? And it is independent of the cardiovascular risk, and it is independent of the comorbidities. So they don't care much whether you have diabetes, whether you have CKD. So it is always a range, and range is not that different, except in older people where they go for a higher step. You don't lower the blood pressure very much, as much as the younger people. But this is different from the previous guidelines. The previous evidence was that even especially the people who are elderly, the systolic pressure should not be below 150. But spring trial changed it because there are a lot of patients with over 75 years of age, and they also equally benefited, same magnitude of benefit in terms of death, total deaths as well as cardiovascular deaths and other cardiovascular outcomes. That's why they have come down even for the elderly people, the targets, right? So when it comes to the treatment, how do you manage this patient to achieve this goal? There are two ways of achieving. That is lifestyle changes for all, and drug therapy. Is it for all? No, not for all. Maybe selected group of people. And so as I said, when you try to start the treatment, goal is to have the sustained normotension, and it should be lifetime low blood pressure from that point onward, right? And so what are the lifestyle changes? These are the few of the things, and they are also effective, right? They are, if you enforce them, and it is like prescribing one or two drugs, right? So if you prescribe them properly to achieve these few of the targets regularly, and it is like giving you can skip one or two drugs from that patient's drug list, right? And what about drugs? Drugs have been shown to be effective. Even this registry data, this is one of the, I think this is the Framingham data, that is where the hypertension and many other risk factors were identified as cardiovascular risk factors. Very old study, is a prospective cohort running even now. So they have found the treatment will improve the total number of deaths. That dying from any cause will be reduced by treating your hypertension with medicine, right? And that is the important evidence. And so then coming to the drug therapy, do you give it in all? I said no. And whom you will give in all, where you will classify them as having higher blood pressures. Below, this is called grade 2 and grade 3. That is in European standards. Then it's about one step below in American standards, because their starting pressures are low. You will start drug therapy early, right? Immediate means, very early. As you diagnose, your diagnosis takes time, right? Diagnosis takes repeated measurement. But when you decide, you categorize, and then you start drugs. You don't wait, right? And also you don't wait even if the blood pressure is just mildly raised. That's why you assess the high cardiovascular risk. And the risk assessment, Dr. Mubarak was telling how the risk assessment, European Society of Cardiology gives very clear method of categorizing cardiovascular risk into four groups: low, moderate, high, and very high. Now he added the extremely high risk, right? That is also 5 groups, right? So if it is more high or above, right? High, very high, or extremely high, those are the people that he was telling about, right? CKD, more than moderate CKD, and familial hypercholesteremia. And if you don't have anything else, then asymptomatic. You go by that score chart or any other risk scores, and that is calculated risk is more than 10%. And even in the mild hypertension, you will start drugs very early, right? Another thing, as I said, during our workup, we will look for subclinical target organ damage. You will look at the fundus, you will look at the microalbuminuria to see the renal damage, right? You will do a ECG, you will do maybe do a echo to find out there's LVH. If they are there, you find them, and then you also don't hesitate to start drugs, even the blood pressure is mildly raised. But even in other cases where you don't get high cardiovascular risk and no high organ damage, you can wait even up to 3 months and see whether goals are achieved, right? If the goals are achieved, not achieved, you know what are the goals, right? It's mostly range starting from 140, 90 downwards, right? Up to 120, 120, 70. So this goal is not achieved, then you can start drug treatment at that point, right? And what about, is there a place for drugs for what is called normal pressure, normal blood pressure? So there's a place for drug therapy in high normal group in European guidelines. And if they have particularly coronary artery disease, right, not stroke, right? Stroke, they have a higher threshold to start drugs, right? About 140, 115 Europeans and 140 in American guidelines. This is mainly if you have coronary artery disease. In terms of established coronary vascular disease, even people have so-called normal blood pressure, you will consider blood pressure lowering tablets to prevent cardiovascular events, right? Cardiovascular events in that group of people. And how do you do arrive at choose the drugs? You know, always these are the established first-line drugs, 3 classes of drugs, right? And in specific circumstances, you will choose a drug from one of these other agents, and these are mainly for specific indications. Otherwise, first line is one of the 3 classes, right? And there's a tendency to nowadays more tendency to start combination of therapy early, right? And but it in grade 1 mildly hypertension, it is monotherapy. For younger people, ACE inhibitors are preferred to start. And older people, CCBs, calcium channel blockers. But if they have diabetic, whatever the age, you can, the ACE inhibitors will be beneficial, especially if they have microalbumin and renal related diabetic complications, right? But most of the time, it is a combination of 2 drugs from two different complementary classes, and that each drug should be low dose. You don't start with full doses of 2 combinations. That is low dose combination therapy, right? And now what do they say is to fix that into a single pill, right? And that is the new tendency to improve the compliance, right? That is what single pill combination therapy, that is the meaning of it, right? Okay. And if that is not available, you have to go for 2 combination of medicine or 2 separate drugs. And that is to start, only to start. And after that, if the goals are not met, sequentially add the escalate your therapy by adding a drug from a different class, right? Rather than then only go to. So these are some of the effective drugs. So effectivity and safety comes from the drug trials, and these are the drugs tested in. These are the groups of medicine, groups of pharmacological agents, and these are the drugs that have been well tested in the trials, right? Just because it's a calcium channel blockers, it might not, you can't tell that all the calcium channel blockers might work equally in terms of reducing the cardiovascular risk unless they are tested in that they have used that particular drug in the trial, right? And so that's why, you know, the amlodipine is a well-tested drug, right? And out of the ARPs, so I was telling about few concepts. So blood pressure control has to be throughout the day, right? So there's a phenomena called exaggerated morning blood pressure. I told that it is related to adverse acute cardiac events. So if it is better if a drug can tackle that problem. And also there is a condition called nocturnal hypertension, where if you take the 24-hour blood pressure monitor, only the nighttime pressure is high, and that they have found it's more related to adverse cardiovascular event. So if it is better to have drugs that will have effects on lowering the exaggerated morning blood as well as lower the blood pressure, right? And blood pressure variation. Blood pressure, as I said, it's a second to second, minute to minute variation. They have when they detect, you know, if you do a central monitor, you will see the second to second variation, right? And if you do the 24-hour monitor, you will see hour to hour variation, right? And if you come get the patient back to the clinic, you will see the difference between clinic to clinic blood pressure variation. And they have found clinic to clinic variation. You should not have a variation, right? And clinic to clinic variation will have adverse events. I think Gruber they did in Jaffna study and published about clinic to clinic variation adverse effects of hypertension, right? So better not to have variation, right? So these are the drugs that will give smooth blood pressure control, and they are evidence based, right? And tested in trials, right? So whatever the drug you give has to be discussed with the patient. That has to tailor to the patient's need, because these are You are treating asymptomatic, largely asymptomatic condition, and this gives drug side effects. So the patient has the option to refuse treatment, right? So that is comes in very high in the treatment algorithms. To discuss with the patient, if they don't like it, that is his decision, right? Okay. And but if you decide to and patient accept, better to treat long-acting drugs exhibiting less blood pressure variation. Longest biological half-lives are seen in perindopril, telmisartan, amlodipine, and clothalidone, right? We don't have it now. I don't think. No, we have a combination. I think atenolol and clothalidone in a combination, right? We don't use because of the atenolol combination, right? And so that is what. This is the longest biological half-life, right? And always these drugs should be affordable, low cost. That is one of the reasons why many third world countries, they don't. Ours is not a big issue because we give it free of charge. The other countries, it has to be, give expensive drugs, they don't take it, right? And so drugs has to be tolerated, minimum side effects, right? So this is about single combination pill therapy. It has to be fixed dose in a single combination. So what is the preferred combination? Or RAS, renin-angiotensin aldosterone system blocker plus CCB or a diuretic, right? That is the initial combination. So what is the best combination? Telmisartan and amlodipine, right? And because this is the longest, having a because smoothness index, that's what I told, least variation, you find it over with this combination, right? But you should never combine ACE inhibitor and ARB together because that will have severe adverse effects, right? And so this is now this is done in Sri Lanka. A lot of our the names, our colleagues are here, right? And this published recently in JAMA. So they have, I think, the Professor Asir Silva is one of the primary investigator. So this concept is being discussed in the latest articles, but has not been related to the practice because they have now as I said, early grade 2 hypertension, they have tried low dose 3 drugs in a fixed combination, right? The other countries, they have 2 drugs in fixed combination. So they have tested this and found results, but it has not been taken to guideline writing committees. They have not considered this one yet, but there are previous trials also. This is a most recent trial by coming from Sri Lanka, right? And so when you come to the timing, right? If you're giving one drug at one time, one drug together, it's okay, right? When you time, it can be either at a fixed time, whatever the time, morning or the evening, right? So soon after awakening and evening, right? And if you are giving 2 drugs separately, so better to split it so that you get the maximum smoothing effect of the drugs, right? And morning, the best CCBs and diuretics are best given in the morning, especially the diuretic. Otherwise, they will start, going to the toilet, and the blood pressure itself will disturb him and sleep. And so evening, RAS blockers and beta blockers that will effectively control the early morning surges. So this is called the chronotherapeutic regime, right? You think about the timing, right? And so the targets are, morning, if you have measured the pressure at home, it should be below 130/80, and early morning surge should be below 40. So if you are doing the 24-hour monitoring, night goal should be below 120/70, right? So whatever you do, as I said, non-adherence is a big problem. People will say you treat asymptomatic patients, right, and ask him to follow them for life, and that is the issue because people will deny, right, and they will cause trouble, including impotence, right. So that's a serious trouble for a young male, right, and it needs a lot of ways to tackle the problem, right. That is one of the reasons why blood pressure remains uncontrolled. So this is what I have to tell in summary. So out of office blood pressure measurements are better, right? That is for the optimal blood pressure management. And you have to get the patient involved and also the other team members. And whatever the drugs you use it rationally. Fixed combination to keep the compliance going, and low cost, less side effects to pay the patient's acceptance. And that all that will address the compliance. As I said, you have to treat the patient because they are not the numbers, because you have to take the patient as a whole and his preferences, his wishes, his cultural influence, as well as the other diseases that we have. Maybe he is having diabetes, he may be having other dyslipidemias, and all that has to be attended, and treat the patient, not the numbers. And so I must thank you. And with this, I think we are in a very bad state with COVID, and whole world is in a mess, and we are going to be each of us should hold this, I think, crystal and go look at the future to the be a crystal gazer and see what is ahead. I think it is not so. It's not so good the future ahead, but we have to think about how to manage the current situations. Especially caring is our specific business is to care for our patients, and I don't know, our clinics are going into worse when caring the management, not only hypertension, but COVID has have a big impact, and to see the world beyond today, right, how it will affect and do something more useful. That's why I think I even especially thank ASM, because they have today, Dr. Madhakeda has broken the capsule of the COVID and asked for us to come for a physical meeting. And we have, I am gathering the speakers, I had I have to get a lot of omission last minute thing because of so-called COVIDophobia, right? And we have to, this is a one step to prevent, getting out of that capsule. Right? I thank you very much.
Thank you very much. Sorry, thank you very much, sir, for that excellent talk on hypertension. I would like to invite Dr. Mubarak to hand over the certificate to Dr. Anidu.